Good afternoon, everyone. Welcome to the Department of Medicine PG lecture series. We are underway a medical oncology lecture series currently, and this is a penultimate lecture in the series. Today we have Dr. Josh taking a lecture on updates in management of breast cancer for us. I welcome Dr. Josh for the lecture.
Hi, good afternoon, everyone. So today, last time, I was given quite a vast topic. I feel this time it's even more bigger because breast cancer would have been an easy topic to take probably in the 1900s, in the beginning of the 1900s. After that, there have been so many advances in breast cancer. It's not just one disease. So, and there are multiple treatment modalities. So, does anybody know why Angelina Jolie was on the cover of Time magazine for something called the Angelina effect? Does anybody know? Anything? Anybody who watches? I'm sure all of you watch Hollywood movies. Does anybody know why Angelina Jolie is? Correct, exactly. So she had a bilateral prophylactic mastectomy because she had a BRCA mutation. So that's why she was kind of a vocal proponent of screening and then prophylactic treatment. So that's why she ended up on the cover of Time magazine, not just for her acting prowess. So it's I mean, breast cancer is something which is very common. I'm sure all of us would know somebody or would have seen somebody or would have kind of heard of somebody later, somebody with breast cancer, right? So it's a very common issue for humanity. So let me start off by asking a question. What do you think is the commonest cancer by incidence in the world? Take a guess. I mean, it's just, just exactly. I mean, you're right. Lung cancer is the commonest cancer by incidence as well as by mortality. And what about the situation in India? Yeah, I mean, you guys would have been right a couple of years back, but currently the leading cancer by incidence is breast cancer. And close second is lip and oral cavity cancer. So that's good. I didn't know that many people knew that oral cavity cancer is very common in India. Did I mention it in the last lecture? Maybe. So, so across human history, we've had breast cancer. So these are two people. One, the first picture of is Dr. Nielsen. She was a trauma physician who was diagnosed with breast cancer. This is her, I think, in the pole. And Tosa, who was the mother of King Xerxes of Persia. I'm sure all of you know Xerxes, right? From the movie 300. So she was a mother of King Xerxes and she had breast cancer. So across, I mean, breast cancer is a disease which is known from antiquity. Any reason why? Why not other cancers like leukemias or GI cancers? Why is breast cancer so ingrained in our in the human memory? Because it's visible, right? So you have a lump in the breast, it's easily visible. So if you have a gastric cancer or something inside, it's not visible. So patient suddenly has, coughs out blood or becomes anemic and becomes sick. People don't know what's happening, right? But then you see the breast cancer growing, it grows, it's kind of ulcerates, it spreads, it goes to the axillary nerves. It's very, very visible and very stark. That's why it's very ingrained in the human psyche. So it's a problem which has been with us for many years. So I think some of the slides, this is the older version of PowerPoint, I think. Sorry, the text is a little misaligned. So initially do you know who Galen was? Galen? Do you know who Hippocrates was? So Galen was a physician in the early Roman period in around 100 to 200 AD. And he was actually one of the leading physicians in the world at that time. So then after that, the world after the Roman era, the world kind of fell into the dark ages, the medieval period and all, and then science and progress after the Roman civilization collapse kind of collapsed and stopped. Then again in around the 16th century, 17th century, again people started rediscovering his works and all, and started reading all these texts, and started again science started to progress. So this was actually one of the first instruments which is used for surgery. So if you have a tumor, you just take it out, right? So this is a crude way of taking out. I'm sure everybody knows who this is, right? Who's the surgeon who's most associated with breast cancer? Halsted, right? Halsted's mastectomy. We have learned in MBBS, right? So we have seen that Halsted, William Stewart Halsted, is sometimes called the most prolific or best surgeon in the world. Though I'm not sure if he himself said it, but so he actually was the proponent of a radical surgery. It was very radical, meaning it took out the chest wall, the muscles, the axillary nodes. So it was a radical tumor. But then what he thought was doing anything short of that was actually not, was a false kindness to the patient, meaning the cancer would recur, right? So he was the one who established the concept of radical surgery. So in the modern era of breast cancer, how do we treat patients? So from that 1900 to 1919, from the last century, what happened was rather than doing a radical surgery, which is very morbid, it's not whatever we have seen during our MBBS course or our MD or our career. What we have seen is actually a modified radical mastectomy, not the radical one which Halsted used to do. So people realize that we don't really need to do such a radical surgery. We can selectively take out certain parts of the chest wall, breast, muscle, lymph nodes. So people realized that less radical surgery had equally good outcomes and epidemiological studies, right? So we began to understand what this disease is, what is breast cancer, how does it occur, radiation therapy, mammography, and chemotherapy. These are the main, advances which happened during the last century. Do you know any connection which cancer treatment has with World War II? Any connection? What is, I mean, these soldiers are all wearing gas masks, right? What is the fear in during World War II? What is the main weapon, like a biological weapon, not a biological, a chemical warfare weapon which is used? Mustard gas, right? Mustard gas. So those sulfur mustards actually, when they fell on troops and when they were exposed to it, what happened is they went into a deep marrow suppression. So that's how actually Goodman and Gilman. I'm sure you've heard of Goodman and Gilman, right? I hope everybody's heard of Goodman and Gilman. So they, as well as Farber, who was of Dana Farber fame, they realized that these chemicals actually cause DNA damage and cell death, and these can be used to treat neoplastic disease. So then the first combination chemotherapy for breast cancer, this name is one thing historically you should know, Bonadonna. So what Bonadonna used was cyclophosphamide, methotrexate, and 5-fluorouracil CMF regimen. This was the first regimen to show that survival improves. Combination chemotherapy improves the survival of patients after surgery. So when patients come to us, right, they'll ask us, why do we need to give chemotherapy anyway? The cancer is taken out, right? So what will you tell them? First of all, are you convinced that patients will require chemotherapy when a cancer is treated? So there are three pillars of treatment today, right? You have chemotherapy, surgery, radiation therapy, right? So there are cases where we omit two of these pillars. Surgery, as of now, it cannot be omitted. Surgery is the curative modality, but chemotherapy prevents recurrences and improves survival by a great deal. So we'll see that. So this is the first study which showed that. Before this, we didn't know, right? Chemotherapy is just a poison. We didn't know that it would improve survival of breast cancer. So then from the era of Bonadonna, we have come a long way. I'm not going to the entire history of breast cancer treatment, but what we have recently found out is breast cancer has, all of us know these types of breast cancer. There are, broadly it is classified into three types. It is hormone positive or HER2 enriched, HER2 positive or triple negative. These are the three types of breast cancer. But then a study by Lehman et al., they found that that is for triple negative breast cancer. But what we understood while doing a full genomic sequencing of breast cancer is that this breast cancer can be divided into molecular classifications, and these molecular classifications not always overlap with the classification which we do by the pathology and IHC. So, but this classification, even though it's important to understand in its prognostic, it has not really changed our practice in the clinic. So it's good to know that there is a molecular classification. It may become more relevant in the future, but it is not directly implicated. And so we don't do this molecular classification for all patients. What we do is this. So in clinical practice, we see for estrogen receptor and progesterone receptor expression on the cancer cells by IHC, immunohistochemistry. We look for HER2 expression, overexpression of the protein or the gene. And then if both are not there, it is triple negative breast cancer. So then why why do we give chemotherapy, right? So if a patient asks me in the clinic, every patient would ask, do I really need chemotherapy? So that's a very good question, actually. So if you give adjuvant chemotherapy, you may increase survival by maybe overall across all cancer, all types of breast cancer, around 5% to 10%. That's how much you would increase. But then if you have a risk of heart failure because of anthracycline chemotherapy or because of trastuzumab which you're giving, does that really help? You're balancing out the benefits with the risks. So then each patient, we need to actually, so everybody, initially we didn't know what types of breast cancer were there. Everybody got surgery. After that, everybody got chemotherapy. And most people, if they have certain criteria, they got radiation therapy. So then now comes the time where we kind of divide these patients, each type, into subtypes, and based on their risk, decide what treatment we need. So there came a time when Halstead's time when escalation of therapy was there. Then we try to de-escalate therapy where we want to reduce the risks of treatment and improve the benefits of treatment. And sometimes in some settings, even now, we are trying to escalate therapy because the therapies which we have are still not good enough. So let me start off by talking about triple negative breast cancer. So this presentation will be divided into early breast cancer and metastatic breast cancer. By early breast cancer, I mean breast cancer which is present in the breast and has spread to the lymph nodes, the axillary lymph nodes, sometimes the internal mammary chain, sometimes the supraclav node also, which is still not considered metastatic. It's still stage 3C. This is early or locally advanced breast cancer. Like metastatic breast cancer means it has gone to another organ, or even cervical lymph nodes is considered as metastatic breast cancer. So triple negative breast cancer means this estrogen receptor and progesterone receptor are expressed in less than 1% of the cells. There is another definition also which says 10%, but the stricter, more prevalent definition is less than 1%. And HER2 negative means either the immunohistochemistry is negative, or immunohistochemistry means we take the pathology slides and look at the surface proteins, the expression. The gene of HER2 is called ERB2, and that gene actually, how the protein expression increases is because the gene copies increase. So we can detect that by FISH testing. So if IHC is 0 or 1, it is negative. If IHC is 3 plus for HER2, it is positive, and 2 plus is still borderline. So then we have to do the gene copy number by FISH. Then only we can say that it is HER2 overexpressed or negative. So 10 years ago, triple negative breast cancer, we had only chemotherapy, right? So we didn't have any targeted therapy because it's not positive for ERPR, it's not positive for HER2. So then even survival, suppose in metastatic disease, survival was around the range of 1 year. Like patients did not live beyond 1 year if you have metastatic disease because we had only sequential single agent chemotherapy to give them. So then in triple negative breast cancer, what happened was generally the treatment which is given us, I'm sure all of you know about these drugs, right? So it's called ACT, right? If anybody asks you what is the chemotherapy for breast cancer and you want to write some answer in the exam, you'll be correct most of the time if you write ACT, which is anthracycline, cyclophosphamide, and taxane. This is usually paclitaxel or docetaxel. So this is the chemotherapy which is there. Now, the questions which people wanted to ask was, should we give 3 weekly or 2 weekly? Should we avoid anthracycline? Can we reduce it to 4 cycles? This is usually 4 cycles of doxorubicin cyclophosphamide followed by 4 cycles of paclitaxel. That's what we usually give as chemotherapy. This is in the adjuvant setting or the neoadjuvant setting, meaning before surgery or after surgery. So then people started asking these questions. Should we add a platinum agent like carboplatin, cisplatin? Can we omit chemotherapy altogether? Should we give adjuvant or neoadjuvant? Should we give capecitabine as adjuvant? So all these questions, how do we answer these questions in today's modern medicine? Suppose you have a question about a disease, how do we answer that question? All these questions. What would you do? Like if I ask you, shall I make it 3 weekly or 2 weekly? What would you do? It's a simple question. You want to do a comparative study, right? And the best comparative study which you can do currently is a randomized controlled trial, right? So for all these questions, most of these questions, you have randomized controlled trials which have answered these questions. So I'll just go through. So that is how our treatment. So from ACT, what has happened? That is what I'm going to discuss with you today. So why do we? So there was a time when most patients in breast cancer had upfront surgery. When a patient comes to us, obviously, if I'm a patient of breast cancer, do you think males can get breast cancer? Males can get breast cancer. Okay, and their breast cancer prognosis with the same stage and same lymph node is actually worse because the tissue is less. So breast cancer, if I have breast cancer, do you think I'll be okay with keeping the tumor there? I can see the tumor, right? It's there, and keeping the tumor there and just giving chemotherapy. Will you be okay with that? So that was the mentality. Even now, that is what most patients feel, that they, should be taken out as soon as possible, right? That's what any sane person would do. But that's what even the surgeons would recommend. So everybody had surgery upfront, and then later on we had chemotherapy and radiation adjuvant therapies. But then we found that there are some advantages to giving chemotherapy initially. So one advantage is that one thing is that there's no difference in overall survival. Neoadjuvant, adjuvant, if you give it before surgery or after surgery, it's the same survival. There's no survival difference. But what is different is, if you have a large tumor and you give chemotherapy, instead of doing a mastectomy, taking out the full breast, you can actually do a breast conservation. Just do a wide local excision and just do a sentinel lymph node or maxillary node dissection. So that is one advantage of giving neoadjuvant. The other advantage is, all of these cancers, especially triple-negative breast cancer, they're not the same, right? So if you give a treatment and the patient does not respond, right? Suppose you take out the tumor, okay, and you give chemotherapy. How do you know that the tumor is going to respond to chemotherapy? Is there any way of taking the tumor and testing it for the? I mean, there are ways. Okay, there are something called organoids, but those are not really common to clinical practice. But is it possible that you keep the tumor there, you give chemotherapy, and then you can see the response, right? The tumor will shrink before your eyes. The tumor sometimes, like in triple-negative breast cancer, 30 to 40% of the time, the tumor completely disappears with chemotherapy. So at the time of taking out the breast, there won't be any tumor left. Like, it's pathological complete response. This is a good prognostic indicator. So that prognostic indicator we won't be able to get if we do a upfront surgery. So that is another advantage. The higher local recurrence rate is slightly higher, but that may be because more of breast conservation surgery is done, but that does not affect survival. So then we have moved away from adjuvant chemotherapy to neoadjuvant chemotherapy for triple-negative breast cancer and for HER2 positive. For hormone positive breast cancer, we still consider adjuvant therapy as the standard of care. So there are questions. So these trials I'm not going to discuss in detail, but I'm just going to tell you that the treatment which I told you, right, anthracycline and taxane. So initially we had CMF, which had come, which is the Bonadonna regimen. Then we understood that adding an anthracycline improved survival. So without chemotherapy versus anthracycline was 47% and 39% recurrence rate. Then we found out that adding anthracycline and taxane improves survival further. So this is how these two treatments came. That's why the standard treatment came as ACT, anthracycline, cyclophosphamide, and taxane. Trifluorouracil and methotrexate were not being used anymore currently in the curative setting. So this is a large meta-analysis which proved that. The second question which I asked, whether to give 3-weekly chemotherapy. So usually we give one dose, ask patients to come back after 21 days. But then we found that clubbing it together, right? Giving cancer cells not enough time to recover, giving it to put it simply, 2-weekly, giving treatment very dose dense actually improves survival, reduce recurrence rates and improve survival. So then we learned that we should give treatment every 2 weeks. So after this was the standard for quite a long time. But what is the problem with this anthracycline, doxorubicin and epirubicin? Do you know of any problem with these drugs? Cardiac toxicity, excellent. So cardiac toxicity, so these can cause decline in the LV systolic function. This which is dose dependent and more for doxorubicin, less for epirubicin. But around 3 to 4% of patients can have asymptomatic decline, and then even 1 to 2% of patients can have heart failure, clinically evident heart failure. So then what we found was, sometimes in early breast cancer, very small tumors, node negative tumors, we can omit the anthracycline. These are all large randomized trials which have shown this. So then we found out that if we just give taxane cyclophosphamide, omit the A in the ACT, just give taxane cyclophosphamide chemotherapy, it is kind of similar to giving the full ACT. So there was a trial called the Plan B trial from Germany, which showed that 6 cycles of docetaxel cyclophosphamide was non-inferior to giving full ECT, 4 cycles of EC followed by 4 cycles of T. So then this is what I mentioned about de-escalating therapy. Like we reached a point where, we have achieved good cure rates, and then we want to reduce the toxicity. So this is one de-escalation step. So that is some questions which were answered with those trials. Now, another thing which we learned was in triple negative breast cancer, the thing which I mentioned earlier, this pathological complete response, right? Completely, the tumor completely disappears at the time of surgery. So if you look at this, and all of you are familiar with Kaplan-Meier curves. If you look at this, these are patients who had PATCR. These are all same category of patients who underwent the same treatment and then had PATCR. Their survival is much better than patients who did not have PATCR. This is a large, around 10,000 patient study. One was 5,000 patient, another was a 10,000 patient study. So this showed that in triple negative breast cancer, predominantly, PATCR is a very good prognostic indicator. That's why we prefer to give neoadjuvant chemotherapy for everybody. So then the question arose. So patients who have PATCR are very good. So they have a good survival. They have very good cure rates. But what about those patients who do not have PATCR? What would you want to do? You want to escalate therapy, right? Because whatever you gave before surgery really did not touch the tumor, right? It's still there. It's still alive. It's still kicking. So you want to give further therapy so that it improves survival. So to answer this question, there was a trial called the CREATE-X trial, where after neoadjuvant therapy, those who had residual disease at the time of surgery, they were given oral capecitabine tablets for 6 months, and this improved survival. So then this became another standard of care. This is one of the questions which I had put up in the initial slides, and this was answered. So this trial actually took all patients with HER2 negative, meaning hormone positive and triple negative, but the survival advantage was seen only with triple negative breast cancer. So then that became the standard of care. So then, so now we learned that anthracycline taxane is important. Sometimes we can avoid anthracycline. PATCR is important. And then in triple negative breast cancer, after all this treatment, we can give capecitabine as adjuvant therapy after surgery. So then the question came whether to add platinum. Platinum is carboplatin or cisplatin, but predominantly the world has used carboplatin. So there were these 3 studies which are not really powered to detect overall survival, but what they found was this PATCR increased when we gave. So if you give ACT, PATCR is around 35 to 40%, meaning the complete response. But when we give platinum, the PATCR increased to around 55%. So then people decided to add carboplatin to this treatment, neoadjuvant treatment. But unfortunately, no trial really demonstrated that it improved survival. So all in oncology, most trials, the real endpoint which we really want to achieve is survival, right? Who cares if the patients, do they really care if the tumor shrunk a little bit or if tumor disappeared? And then what we want to achieve is improved survival, right? I want to live longer and I want to have a good quality of life. So these are the only 2 outcomes which are important for patients. So that is the outcome which should be tested in all trials. But unfortunately, to test an overall survival advantage between 2 treatments, it takes a very large sample size. So most of the trials kind of check surrogate outcomes, which happened before that. Disease-free survival, decreased chance of recurrence, PATCR. So these are all surrogate outcomes for overall survival. So then, unfortunately, these studies did not find an overall survival benefit. Recently, in around 1.5 years back, this is Dr. Sudeep Gupta from Tata Memorial Hospital. So their trial actually showed, this is a large phase 3 randomized trial, which showed that carboplatin, when added to patients receiving neoadjuvant chemotherapy for triple negative breast cancer, improved survival. So this is the first trial actually which is showing an improvement in overall survival. And this has not been published yet. He's presented it in SCBCS in 2022. So so then the world has really kind of almost adopted carboplatin. From our own department, we have some studies of cisplatin. We generally prefer cisplatin. Our HOD sir, Ashish sir, he also prefers cisplatin, though this is not the standard of care. I'm not telling you to give cisplatin. We have had some studies which show that cisplatin also has similar PATCR rates and even possibly even better survival. So we are investigating that in randomized trials. So there is this is currently this was the treatment for triple negative breast cancer, right? So there is something called TNBC DX, which I'll come to later. If any of you remember at the end of there is something called Oncotype DX. So if you remember, you can ask me at that time, what is that TNBC DX? Do you know who these two people are? They won the Nobel Prize for medicine in 2018. For what did they win? Do you know? So these people, if anybody is interested in oncology or cancer related fields, these people should be known, right? So they actually discovered that inhibiting checkpoints of the immune system really kind of triggers the immune system to attack cancer cells. Okay, I'll explain that later. So this is James P. Allison from MD Anderson and Tasuko Honjo from Japan. They simultaneously discovered this. So their initial discovery was in the CTLA4. So inhibiting CTLA4 actually allowed the T cells to attack tumor cells. So immunology we have studied long time back, but do you remember what is co-stimulation? Co-stimulation for the activation of, so it's quite simple. So you have an antigen presenting cell and a T cell, right? So the antigen presenting cell through MHC class 1 will present the antigen to the T cell receptor, right? So that is one signal which happens. That is only signal one. That alone, if it happens, it will not activate the T cell. You should have another signal where CD80 or CD86, B71 or B72, other names for it. So that binds to CD28. So these are the two signals. So only this signal and this signal comes, and both these signals are there, the CD8 T cell will get activated. Okay, otherwise it will not get activated. So then if these two happen, the T cell gets uncontrolled activation, it will be a problem, right? Autoimmune diseases will happen. So there is a mechanism within the cells itself, which actually suppresses this activation. So that two molecules which they discovered, this is only the beginning of immunotherapy. Okay, there are so many other molecules which are coming, so many other targets which are there, but this is the beginning. So this is, even now it's actually quite old. So CTLA4 and PD1 and PDL1. Where is PD1, PD1? Okay, see, PD1, PDL1 is not there, but PD1 and PDL1, I think it's there in the previous one. Yes. So this blue thing, right? So what happens is when PDL1 is on the cancer cell or the antigen presenting cell, and PD1 is on the T cell. So when these bind, this co-stimulation or the activation of the T cell gets lost. Okay. So what if we can inhibit it? Then the T cell will be able to kind of recognize the cancer cell as a foreign antigen and attack it. So that's what we're doing by giving PD1 inhibitors or PDL1 inhibitors. They act on the same axis, so they're not really very different. So what happens is, this is the co-stimulation. So if you have the B7 is that CD80, CD28, and MHC class 1 and T cell receptor. So if it is activated and you have these antibodies which are coming in and preventing this PD1 binding from PDL1, then this activation can happen and the T cell will go and attack the tumor cell. So this is what they discovered. They discovered it initially in CTLA4, but we generally more effective therapies are by PD1 and PDL1 inhibition. So generally, cancer is not really, we understand that cancer is not really, it's not a disease, which this tumor grows, we give chemotherapy, it dies. It's not like that, right? So if you keep on giving chemotherapy, generally we can't really kill that last cancer cell, right? There is a log kill hypothesis. So the few cancer cells which remain after chemotherapy or treatment, these immune cells, our immune cells go and clear it off. So how does cancer develop? So usually there are three stages. One is called elimination, where when a cancer cell develops from normal tissue and it has neoantigens, tumor antigens, it is usually eliminated by our immune system, right? But then the cancer cells will develop some mechanisms whereby, like PD1, PDL1 overexpression, and other immune evasion mechanisms, where it becomes in equilibrium, right? It remains dormant. So daily in our bodies, cancer develops. All of us are developing cancer cells, okay? But then our immune system kind of take care of it, luckily for us. So if that kind of fails and the tumor cells kind of can evade the immune cells, either by reducing the expression of MHC or by reducing neoantigens on the surface. There are various mechanisms. Increased expression of PDL1, they evade the immune system and then start proliferating. That's a simple mechanism of how the immune system kind of controls development of cancer. But realizing that PD-1 inhibition or PD-L1 inhibition can target cancer, we realized that if initially the trials were in melanoma, right? Melanoma is a disease which doesn't respond to chemotherapy, but we found that inhibition of CTLA4 and PD-1 or PD-L1 really improves survival in melanoma, really like dramatically improves survival in melanoma. We don't see so much melanoma, but in the Western population, we have a lot of melanoma. So pembrolizumab is a PD-1 antibody, which actually, there's a lot of history behind development of pembrolizumab. But after all these questions of, whether we should add carboplatin, whether we should add, capecitabine as adjuvant, whether we should omit anthracycline, this is the next question which was asked. If we add pembrolizumab to all this treatment which we're giving, so we're giving all this anthracycline, taxane plus carboplatin in this trial, which is the keynote 522, and we add pembrolizumab in the neoadjuvant phase and then continue it for up to 1 year, which is 8 cycles before surgery and 9 cycles after surgery, total 17 cycles, which is 52 weeks. So if you give that, then what happens is, this is an NEJM publication. So what they found initially was the pathological, that complete response, that very good prognostic indicator, which I mentioned, that actually improves from 51% to 65%. So from normal chemo, 35%, platinum increased it to 51%, then you increase it to 65% with immunotherapy. So generally that means that survival should improve, and that is what is happening. Overall survival, they recently published another paper in NEJM where they showed that with pembrolizumab and chemotherapy, at 60 months, overall survival estimated, that is 5 years, right? 5 years survival is 86% compared to just the other group, which is lesser. It's around 81%. So then you can see that the survival is quite good, right? So this is triple negative breast cancer, which is the worst type of breast cancer, right? So you can see that 86% of patients surviving across all stages 1 to 3 is actually quite a good thing. We should remember where we came from, like from the Bonadonna study. And so that is one treatment which is added to the arsenal. Now, the next treatment which is added to the arsenal is something called PARP inhibitors, olaparib. Does anybody know what PARP inhibitors are? Okay, there is a principle called synthetic lethality. So these cells which have a BRCA mutation, like what I mentioned earlier about Angelina Jolie having the BRCA mutation. So these cells which have a BRCA mutation, BRCA is basically a gene involved in homologous recombinant repair of DNA. And base excision repair is what is done by PARP. So when you have a cell which has BRCA, which is knocked off, and you go and knock off PARP1 inhibition with a tablet, olaparib is an oral tablet, then you cause cell death in those cancer cells. So when they divide, what happens is they will have whatever other mechanisms which, other than homologous recombination and the PARP mediated base excision repair, the other mechanisms are really very error prone. So once it divide, there are various errors which happen and the cell dies. Okay, it's not, the instability in the genome is too high that it's not viable. So the cell dies off. So that's a principle. And then what they did was they gave this PARP inhibitor to patients after surgery who had residual disease, who are not HER2 positive. HER2 positive is a completely different disease, but those who are not HER2 positive, they gave PARP inhibitor, and then that improved survival, right? So that improved overall survival. So that again, another drug which is added to the arsenal. So then I mentioned a lot of questions, lot of trials, lot of this thing. It is very confusing, even for us. Sometimes the rate at which studies come out, studies are done, it's quite difficult to keep track of. But very simply done, very simply, I've just made few points. If it's a very small tumor, T1A less than 5 mm, we can actually just observe the patient also. Especially if there's a marker called TILs in the pathology specimen, there are a lot of tumor infiltrating lymphocytes. You can actually just observe the patient. If the patient has bigger tumors, you can give them neoadjuvant chemotherapy if they start from T1B onwards, and T1C also neoadjuvant chemotherapy. If it's a smaller tumor, you can still avoid this anthracycline and platinum in early tumors in TNBC. If you feel that it's a bigger tumor, then you can actually give them the full 4EC 4T. Now, if the patient has stage 2 to 3 TNBC, ideally you should be adding platinum now, because although we have only one trial which showed carboplatin has a benefit, but to chemotherapy ACT, we should be adding platinum. And most of the centers in the world give carboplatin, including in India. But in our center, it's a little different. We are using cisplatin. So patients with, also you give neoadjuvant chemotherapy, right? Patients have PAT-CR. Then what do you do? If patient has PAT-CR, if you have given pembrolizumab in the neoadjuvant setting, the only problem with pembrolizumab is very costly, right? So per dose, it's around 2 lakhs. So the full cost of, that 17 doses of pembrolizumab itself will come to nearly 20 lakhs. So that is extremely costly. We don't have insurance reimbursement in most patients in India. So it's very difficult. So we are actually doing some studies where we're seeing whether low dose nivolumab will work. So that may be something which will be applicable to our population, because most of our patients we cannot give this. So patients without PCR, we can give them either capecitabine, or those who are BRCA positive, we can give them olaparib. And along with this, if we give pembrolizumab, we can give pembrolizumab. So this is how the treatment has evolved right now. So this is the same thing. I'm just mentioning it with stage. So that is triple negative breast cancer, right? Early breast cancer. Now coming to hormone positive breast cancer, it gets a little more complex. So, but it's I'll just try to kind of just simplify it in very so that we can remember what to do when we see a patient. So endocrine therapy, like all of us know that hormone positive breast cancer. What does it mean, right? Is it producing hormones, or what does it mean? Yeah, so basically it means that the estrogen receptors are it's overexpressed, and that pathway, right? So what happens when estrogen binds to the estrogen receptor? So the receptor actually goes directly into the cell, into the nucleus, and into the DNA, and then binds to hormone response elements, and binds to estrogen receptor response elements, and then activates certain genes which produces cell proliferation and survival. Right. So that's what happens. So if you inhibit that target, I mean, inhibit the receptor, with what can you inhibit it with? I mean, you would have heard of tamoxifen, you would have heard of aromatase inhibitors. So either a SERM or an aromatase inhibitor, or just suppressing the function of the ovary. These are treatment modalities which we know. Then the other treatment modality is chemotherapy, and the third treatment modality is radiation therapy. This is all the adjuvant therapies which we give. Right? So tamoxifen, right? So initially what we did was, if you have surgery and then you gave chemotherapy, giving tamoxifen for 5 years really improves survival, right? It reduces the recurrence rate and it improves survival. So that is standard, right? That is a baseline. So whatever I am saying right now, what you can think of it as like we're building up on a pyramid, right? So baseline, we need to give all patients who are ER positive, all of them should receive adjuvant endocrine therapy with tamoxifen or letrozole, which is an aromatase inhibitor. So between aromatase inhibitor and tamoxifen, uh, we would prefer to give an aromatase inhibitor, because studies have shown that there is a reduced chance of recurrence, although small. But premenopausal women, we should give them tamoxifen, right? Can we give aromatase inhibitor to premenopausal women? We should not give them. Their ovaries are still producing estrogen. The aromatase inhibitor will only inhibit peripheral production of estrogen, right? So we should not give them aromatase inhibitor if they're premenopausal. Postmenopausal women can take both. They can be given tamoxifen or aromatase inhibitor. We would prefer to give them aromatase inhibitor. So you have adjuvant endocrine therapy with tamoxifen, with aromatase inhibitor. Then there is something called ovarian function suppression for patients who are premenopausal, right? So if you give them ovarian function suppression, that means you're basically inducing menopause. You're inducing it early. So that obviously has a lot of not lots, like it has some adverse effects, but it has improved disease recurrence rates and survival in certain situations in 2 trials called the soft and text trials. So that is also one part of the armamentarium. So this is a NCCN guideline for just the endocrine therapy. In simple terms, so if a premenopausal patient comes, we would give them 5 years of tamoxifen, right? That is one option. If you give them 5 years of therapy, you can actually continue it with another 5 years of aromatase inhibitor. And at the end of 5 years of tamoxifen, if they become postmenopausal, you can give them either AI or TAM. And if they're still premenopausal, you can just continue giving them TAM. It's a complicated this thing, but in simple terms, what I can say is, if you have a patient who's premenopausal and who's not very high risk, right? You give them surgery, chemotherapy. I'll come to later. When do you use chemotherapy? And then give them tamoxifen for 5 years, right? Very simple. If they are conjum high risk, you can actually add OFS, tamoxifen or AI. You suppress their ovarian function as well, which will improve survival in high risk patients, large node positive tumors. Postmenopausal, simple, you just give them letrozole for 5 years, but extending that 5 years to up to 10 years, 7 to 10 years actually has improved survival. So we would consider that. In simple terms, that is it. So this I already mentioned. Aromatase inhibitor, the main problems are you have joint pain, like small joint pain of the hands. You can have vaginal dryness, bone loss. So osteopenia, osteoporosis is a very big problem. So all aromatase inhibitor patients will get a bisphosphonate also. Usually we give them ibandronate as an oral tablet. Earlier we used to give alendronate. So what is the problem with tamoxifen? Anybody knows what problem tamoxifen has? Usually it causes endometrial cancer, correct? Endometrial cancer, or it can cause deep vein thrombosis. So these are the two things you should remember when a patient is on. I'm saying all this because you will see patients, even in medicine, right? So you will see patients who are on tamoxifen, on aromatase inhibitor, cured of breast cancer, who are on for 10 years. So if they come to you, you should think of these things, right? Suppose they have a limb swelling, you should think of, could it be DVT caused due to? Suppose they have postmenopausal bleeding, or this could it be due to tamoxifen if they're getting? So those are things which should be important. So chemotherapy, generally, like I said, if you say ACT as chemotherapy for breast cancer, you'll be right most of the time. Okay, so you can say, so hormone positive breast cancer, ACT is the chemotherapy which is given. And here also we had trials which showed that early smaller tumors, node negative, you can actually give them just docetaxel. You can just give them TC 6 cycles. So the question comes. So this is a question which most patients will ask in the clinic also. After surgery, a patient has come to you and they sit and ask, doctor, do you think I really need chemotherapy, or can I just take these tablets? So most people would want tablets, right? So who could you give chemotherapy to? So this is the current advances in molecular biology have helped us. The Cancer Genome Atlas and NGS, gene sequencing, has helped us to understand at a genetic level which tumors have a high risk of recurrence. So there are particular gene signatures. We don't know, these companies are actually patented and copyrighted these, so we don't know really what is that signature, but they've identified 21 gene signature for Oncotype DX, 70 gene signature for Mammaprint, this PAM50 EndoPredict as well. But these gene signatures kind of tell us whether patient will have benefit with chemotherapy or not. So there was two large studies, but I'll mention one, which is called TAILOR-X, which is published in NEJM. So this study actually, they did the assay, the Oncotype DX assay, the 21 gene assay. The scoring system, those who are less than or equal to 10, right, less than 11, they did not give them any chemotherapy, right? Only adjuvant endocrine therapy. These are all node negative patients who are just have breast tumors and without N0 patients. Then you had the high risk group, more than 25, where from previous studies, we know that the recurrence rate is high. So we gave them all chemotherapy followed by tamoxifen, okay, tamoxifen or aromatase inhibitor. And in the center, they randomized the patients, those who have recurrence score 11 to 25. So long story short, overall, there is no benefit of giving chemotherapy even in that central group. But for patients who are less than 50 years of age and score is not between 11 to 25 is a big group, but 16 to 25, and then we should actually think of clinicopathological risk factors like Ka67, size of the tumor, age of the patient, whether the patient is premenopausal. Based on this, we can actually offer them chemotherapy also. So this is a summary of it. I don't think this is very important for you guys, but if the simple thing is, if a patient has node negative breast cancer, after surgery, you can do this genetic test. Based on that recurrence score, right, RS, you can decide whether to omit chemotherapy. But all of them should ideally get adjuvant endocrine therapy. So then the other treatment which has come is adjuvant CDK4/6 inhibitor. So then we realized that CDK4/6 inhibitor, I'll just come to later what it is. But when patients had all these treatment, right? So they had surgery, they had chemotherapy, they had radiation, and now you're going to give them tamoxifen or letrozole. But if you add something called a CDK4/6 inhibitor to that, that actually reduces the recurrence rate and disease-free survival in a trial called Monarch E. And there's another trial called Natalie as well. Both these trials showed that adding either abemaciclib or ribociclib as adjuvant therapy, just like I mentioned, capecitabine or olaparib in the other setting, if you add this after treatment for 2 years or 3 years, in case of abema or ribo, you will improve their survival, reduce their chance of recurrence. So these are the treatment armamentarium of hormone-positive breast cancer. So very simple. You do surgery, determine the risk score, see if they need chemotherapy, give chemotherapy. After chemotherapy, radiation based on certain factors. And then after all this, you can offer them, if they fall into the risk group of these two trials, like N2, N3 disease or N1 with grade 3 tumors or large tumors, you can give them adjuvant abemaciclib. So this is the simply put, this is the treatment of hormone positive early breast cancer. Now, HER2 positive breast cancer, I had mentioned earlier itself that it's the overexpression of the protein because of the increased gene copies of ERB2. So this is how we tested. So then going through all these trials, there's not much time. We know all of you have heard of trastuzumab, right? Trastuzumab is an anti-HER2 monoclonal antibody. It's a humanized antibody, and it basically improved survival dramatically. Even worse than triple negative breast cancer was HER2 before this trastuzumab was discovered. But now it has actually improved survival significantly. So then there are a lot of regimens. People gave 2 years of trastuzumab and saw whether that was better. But finally, what we understood was just 1 year of adjuvant trastuzumab is enough, and it improves survival for patients. And that should be given with chemotherapy. So initially we should give it sequentially after chemo, but it should be given with taxane, paclitaxel. So what we do is that ACT, we give AC, and then we give TH. H is Herceptin, which is the original brand name of trastuzumab. So we give paclitaxel with Herceptin. So then all these shorter duration therapy trials all did not really show non-inferiority. So then standard treatment is 1 year of trastuzumab. So patients should not run away after treatment. They should come and take every 3-weekly trastuzumab for 1 year. That's the baseline on which we are now going to build up. So the affinity trial actually compared dual HER2 inhibition, like trastuzumab with another molecule called pertuzumab. And together, when chemo with HP, which is Herceptin and pertuzumab, was given, that actually improved IDFS, invasive disease-free survival, in the adjuvant setting. Then we had the Neosphere trial. So when we found out that pertuzumab plus trastuzumab improves survival in the postoperative setting, we brought it to the neoadjuvant setting. And Neosphere trial found out that this trial did not really show survival benefit, but it improved PATCR. Even in HER2 positive patients, pathological response is a very important prognostic factor. Neosphere and the other trial which tested this was Trifina. So it improved PATCR from around 25 to 30% to more than 45%. Then another treatment which came in was something called neratinib, which is actually a small molecule inhibitor, and that is given after all this treatment. They gave it for 1 year. A lot of patients had diarrhea, right? It was quite a poorly tolerated drug, but then it improved invasive disease-free survival. But because this diarrhea is there, we really don't. It's not really come into much of clinical practice, but it is still an option. So the Catherine study this is an important study. So like I said, for patients who don't have PATCR in triple negative breast cancer, give them capecitabine. Patients who don't have PATCR in HER2 positive breast cancer, you give them this molecule called TDM1, which brings us to an important concept, which is going to be the next wave of cancer therapies, which is called antibody drug conjugates. So trastuzumab is just an antibody, right? It's just going to bind to that receptor which is there. Now, TDM1 is actually, you can see here that it's an antibody. It's trastuzumab itself, but it is bound to something. You have 3 molecules of a payload. It's like a missile with a payload. So it'll go and attach to it, and it's basically a chemotherapeutic agent, right? It's a maytansine derivative which goes in and then causes effect in just the cancer cell. So it's like a targeted missile to the cancer cell. So it's called an ADC, TDM1. So when you give TDM1 after all treatment, patients who have not achieved PATCR, then you found that there was improved survival. So then this is the standard of care. So everybody we give TDM1 now. So currently this is the treatment for HER2 positive breast cancer. If it's stage 1, you can do surgery, and if it's very small, you can observe them. If it's kind of between 5 to 10 or between 10 to 20 you can give them just paclitaxel and trastuzumab for 12 cycles, and then complete that 1 year of trastuzumab. That's enough. So if they're stage 2 to 3, we sometimes now many patients we offer them neoadjuvant HP plus chemotherapy, which is trastuzumab, pertuzumab plus chemotherapy. And then those who have residual disease, we can give them TDM1. Those who don't have residual disease, we can continue either trastuzumab alone or trastuzumab plus pertuzumab to complete 1 year. And patients of very bad disease, who you think, N3 disease, very large tumors, you can still consider neratinib after all this treatment is done. But that is a little toxic treatment. So that completes early breast cancer. I have 2 minutes left to complete full of metastatic breast cancer. So I think I'll just go through just a few important things. So historically, the survival for breast cancer, I think all of us, which cancers do you think are the best outcome, best survival in the world? Thyroid? You said thyroid, right? Papillary. Very good. So all of you know these things. So it's good, man. Your baseline level of knowledge is very high. So very good. You can clap for it. So most people don't know that, right? So you have thyroid cancers. Then any other cancers? Any other cancers? Excellent survival. What did our famous cricketer have? And what did Lance Armstrong have? Germ cell tumor, right? Germ cell tumors. So germ cell tumors, testicular tumors, even in there's no stage 4 for that. Stage 3 only is there because such good survival, right? More than 95% survival. So breast cancer is not really, like that. 5-year survival. The best 5-year survival we have is around 50% for, meaning median survival. 50% patients will be alive at 5 years. You can see that triple negative breast cancer is still quite low. So what we are doing is we want to extend life, but we want to do it with a good quality of life. And we should always discuss with the patient what is their preference, what do they want, what are their goals, and they should have good performance status also. And we should do not harm the patient. That is the most important thing. And we should have a discussion with the patient. So in triple negative breast cancer, generally we used to just give chemotherapy, right? But now immunotherapy has come. In simple terms, this Keynote 355 study showed that giving pembrolizumab, which is the initial that PD-1 inhibition I told you about, pembrolizumab with chemotherapy improved survival in patients who had. So we do an IHC for this PDL1, check how much PDL1 expression is there in the tumor cell. If it's more than 10%, then we give them pembrolizumab. The next thing is new treatment which has come is something called sacituzumab govitecan, which is again an antibody drug conjugate, which targets something called TROP2, which is highly expressed on the surface of breast cancer as well as other cells also. In TNBC, this is shown that in the ASCENT study, it has improved PFS and OS. But you can still see that, survival, this is overall survival. You can see that, this is at 2 years. You can see that the graph is dropping, right? So in a very bad disease, when we get some improvement, we are still happy. But understanding that, we have still a long way to go. So PARP inhibitors, the same thing, olaparib, which is given as adjuvant, we can give them, if they have given chemotherapy, they did not progress on chemotherapy, they responded, we give them this olaparib tablet and it improves survival. So this is another treatment which has come about for triple negative breast cancer. Now, another therapy, which is an ADC, which is called TDXD, trastuzumab deruxtecan, which has actually kind of become more revolutionary because it has 8 molecules of the drug, like deruxtecan. It has 8 molecules attached to that trastuzumab. So then the potency is higher. It has a lot of features which kind of help it become a more effective therapy than TDM1, which is the previous generation. So then this one in heavily pretreated patients with TNBC, it showed improvement in survival. We can see, but still the overall survival, this is PFS. So this drug actually quite improved the overall survival quite significantly as compared to even immunotherapy. So this drug is quite good. It's actually coming. It's not really readily available because it's very costly in India, but we have given it to some patients. So in summary, metastatic, this is the same slide as before. Okay. So in summary, if patients have CPS more than 10, we give them pembro plus chemo. If they have BRCA mutation, we can give them PARP inhibition. And if they have HER2 low, So earlier, only if HER2 was positive, we could give them anti-HER2 therapy. But with this TDXD, even if HER2 is 1 plus or 2 plus with FISH negative, we can still give TDXD, it will work. So that is a revolutionary thing about TDXD. In HER2 positive breast cancer, so the standard treatment is this, right? You give them, I think not much time is there, so I'll quickly go through all of this. This is a picture showing trastuzumab deruxtecan. You can see that there are 8 molecules of the drug deruxtecan in it. So this is a chemotherapeutic molecule. It's a payload which is delivered endocytosed into the cell and acts within the cell only, cancer cell only. And in this Destiny Breast 3 trial, I'll just go through the final chart so that you understand. So currently, earlier what we used to do is we used to give them just paclitaxel trastuzumab and then trastuzumab maintenance. And then when they progress, we used to give them lapatinib capecitabine. This was the treatment. Now what has happened is this pertuzumab has come in, that is first line treatment because of the Cleopatra trial. You give them THP, which is a taxane with Herceptin and pertuzumab, and then give them HP maintenance. Now, when they progress on that, then the option of this TDXD is there. Or another trial called HER2CLIMB showed that tucatinib plus capecitabine plus trastuzumab improves survival even in patients with brain mets. Brain mets is usually quite bad in any cancer, but especially in breast cancer. But this trial had 50% of patients with brain mets and it had excellent response. So that is one good option. TDM1 and TDXD also have intracranial activity. Then once they progress on that, then you have all these options. There's another molecule also called margetuximab. So this is basically, you don't need to know the entire thing. You just need to know that these molecules are there, multiple lines of therapy are there. But even then, we have not really, improved survival too much. But then all these are exciting things because these may improve survival incrementally in the future. So yeah, finally, even though TDXD, TDM1, all these are available, most of our patients who are coming to CMC cannot afford it. So then we still give them kind of, the previous generation of therapies. We try to give them chemotherapy, various combinations, try to sequence it such that, we improve their survival without much toxicity. In hormone positive breast cancer, this is what I was telling you about PARP inhibition. No, this is not PARP inhibition, sorry, CDK4/6 inhibitor. This is a revolutionized hormone positive breast cancer treatment. For the first time in history, stage 4 breast cancer, patients have crossed the 5-year mark, right, with this treatment. So that is why it is quite revolutionary in the beginning when it came about. What happens in breast cancer is you have the estrogen receptor which goes in and directly binds to DNA. You have other pathways which are active. So when you have resistance to this, you can have the PIK3 AKT mTOR pathway active. So what we used to do was, once we give letrozole or tamoxifen, after that, you have mutations in the estrogen receptor gene. So ESR1 mutation happens. So you give them fulvestrant, which is an injection, which is given in both buttocks every 15 days and then once a month. So that injection, it's a estrogen receptor degrader. It degrades the receptor. Then you have, once you progress on that, we give them mTOR inhibitors like everolimus. So this was the initial treatment. But CDK4/6 inhibitors directly binds to the DNA, directly binds to the cell cycle regulators within the DNA. So what happens is, when you inhibit CDK4/6, which is supposed to bind with cyclin D and inhibit retinoblastoma protein, RB, and inhibit the cell cycle, right? So if it reduces, so these things were supposed to bind to RB and then cause proliferation. Now, when that is away, the proliferation signal is stopped. So that is how CDK4/6 inhibitors work. And there are various trials. What we need to know is these 3 drugs, right? Abemaciclib, palbociclib, ribociclib. Among these, abemaciclib and ribociclib have shown the best survival data, but they have side effects, right? Abemaciclib has diarrhea. These are all oral tablets. So patient with stage 4 breast cancer, chemotherapy is not given until patient progresses in a host of other therapies. So it's chemotherapy free treatment. You remember the question I asked initially, do we need chemotherapy? We don't need chemotherapy in ER positive metastatic breast cancer for a long time. So patients start with letrozole or aromatase inhibitor, letrozole or tamoxifen plus abemaciclib or ribociclib. After that, when the patient progresses, we have various other therapies, which kind of, I am not going through all of these. But once the patient progresses on that, we do an NGS and find out what is the mutation within the cancer cell which is causing the progression. So if you have a PIK3CA mutation, you have a drug to inhibit that called alpelisib. The trial is there. If you want the slides, I can give to any of you can ask. If you have any mutation within the AKT pathway, you can give AKT inhibitors. There was a trial called Capitolo, which tested capivasertib, which is an AKT inhibitor. If any mutation is there, plus endocrine therapy, which is fulvestrant. If you have an ESR1 mutation, you can use an oral SERT. Like fulvestrant, you have an oral tablet now called elacestrant. And if you have a germline BRCA mutation, you can use olaparib. So these are the main therapies. And if none of these mutations are there, and if patient has HER2, even HER2 1 plus or 2 plus negative, you can use TDXT. And sacituzumab govitecan in this TROPICS trial has shown benefit even in HR positive breast cancer. So that is the overall summary of treatment of breast cancer. It's a very short duration of time. I know it's confusing. I'm sorry if I've gone too fast, but what is exciting is that this is only the start of immunotherapy, ADCs and also. If you're interested in, entering this field, now is the time. And, this is just one anti-TIGIT. Okay, it's another immune checkpoint inhibitor. So anti-TIGIT therapy, there are more than 30 molecules which are now currently under active investigation. And other immune checkpoint inhibitors, there are more than 200 molecules which are under investigation. Not all of them will come to the phase 3 trials and all, but it's an exciting time to be in oncology. Thank you. Thank you.
Thank you so much, Dr. Josh, for that lecture. Any questions from the audience?
Yeah, sure. Yeah, I think that's a very important thing. I actually put some 20 slides initially for evaluation of breast cancer screening and risk factors, but then I realized there's no time for it. So then the topic given was updates in breast cancer management. This is a very good question. So practically what he's asking is, if a patient comes with a breast lump or an ulcerated lesion, what do you do, right? So first of all, clinical examination, history, how long has the tumor been there? Is it growing rapidly? Is it showing any skin? Is it showing any changes in the skin? Does the patient have any family history of treatment? Does the patient have any hormone replacement therapy which the patient has taken? Does the patient have history of other related cancers like hereditary breast ovarian cancers, ovarian cancer, pancreatic cancer, prostate cancer in the family? All those should be asked. So definitely a proper history should be taken for metastatic disease like bone pain, whether the patient has headache, whether the patient has swellings anywhere else in the body. This is very important, right? So a good baseline history, good physical examination. So you examine the affected breast, axilla, as well as the normal breast and axilla, as well as do a systemic examination. So after this, you're convinced, right? There are features to suggest a hard mass, which is either fixed to the skin or fixed to the chest wall. If you have infiltration in the skin, peau d'orange appearance. So any of these is there, you're kind of suspecting, that this is definitely a breast cancer. So what we would do is we would do what is called a triple assessment, right? So first, we would definitely have a suspicion that it is cancer. We do an imaging. So imaging wise, you would do an ultrasound of both breasts and a mammogram. So that's what's recommended currently. You do an ultrasound and a mammogram, and that will tell us a BI-RADS scoring system. Anything which is BI-RADS 4 and above, you should consider doing a biopsy. And even if it is BI-RADS, not BI-RADS 4, but clinically you feel that this is definitely a malignant tumor, we would still go ahead with a biopsy. So outside people do a FNAC, which is not sufficient, right? So you should do a core biopsy, core needle biopsy, which usually our endocrine surgeons or general surgery department does it. Do a core biopsy, send it to pathology, and then the pathologist will tell us like what is the histology and what is. So remember that DCIS, ductal carcinoma in situ, is not invasive cancer. That just needs a mastectomy and tamoxifen. But if it's invasive ductal cancer, you should that is cancer, that is breast cancer, and then you should ask immediately they will do it themselves, but the pathology department here is excellent, so they will do the ERPR and HER2 immediately and tell you the answer within a few days. Then once you have that information, so you did the ultrasound, mammogram, you know that it's BI-RADS 4 or high, you find that it is breast cancer on biopsy, then you evaluate the patient for baseline workup. So you need to do at least a chest X-ray. So in early breast cancer, you can do a chest X-ray. You can just do an ultrasound abdomen because the lung and the liver are usually the first sites of metastasis. If the patient has any symptoms, you should do symptom-directed assessment. Bony pain or something, you should do a full bone scan or a PET scan. But most of our patients cannot afford it. If they have headache or something, you should definitely do an MRI brain baseline itself, because HER2-positive breast cancer, triple-negative breast cancer, very high incidence of metastasis to the brain. So that is one thing we should do. But early breast cancer, you should just do at least an X-ray and ultrasound abdomen. And if it is not very small tumors, you should do a bone scan as well. So these are the basic things which you do for evaluation of the tumor. Once you evaluate the tumor, all patients ideally should go to endocrine surgeon or a general surgeon who's experienced in breast cancer surgery, radiation oncologist, and to us also. And we usually discuss in a multidisciplinary team meeting to decide what's the therapy. So that's the baseline assessment. Does it answer your question?
Thank you so much for the lecture. Are there any other further questions? Thank you so much. Then we'll have a last lecture on medical oncology next week. So please join us for the same. Thank you.